Assalamu alaikum. So today we continue to talk about diabetes mellitus, but we're talking about today mostly type 2 diabetes, okay? I think, and the complications. But again, I'm ready for any questions you have. Okay, so we did this last week. شو قلنا, what is the definition of diabetes mellitus? As characterized by hyperglycemia. Thank you. All right, and قلنا the classification. Does it still any doubts about classifications 1 and 2 and monogenic and LADA, and are those clear? Yes? Okay, so we're talking today about type 2, which is the most common type of diabetes mellitus. Prevalence wise, this is the most common type of diabetes mellitus. Okay. Now, so here you go. It's 80% of diabetes mellitus في العالم is type 2. And it usually develops in adults. تمام? But that doesn't mean you cannot have children coming with type 2 diabetes. Okay? So we do see children age 9, age 10 presenting with new onset diabetes mellitus. That's not type 1. How do we know it's not type 1? Thank you. So we check the antibodies and they're negative. Okay, so it's not. And they might have other signs, that they're overweight, there's a strong family history of type 2 diabetes, so we think this is type 2 diabetes. Now, 80% of patients with type 2 diabetes are either overweight or obese. So one of the biggest risk factors here is weight, اللي هو overweight أو obesity. Now, usually my type 2 diabetes, unlike type 1, ممكن تكون has been there for some time before the time of diagnosis. يعني it doesn't start acutely or subacutely. It has a gradual, insidious onset. Okay, so the patient might not, إذا كان البيشنت مو من النوع اللي he goes and does frequent blood tests, مسرسب وبروح بخاف على حاله عنده OCD وكل شوية يسوي blood test في الهيلث سنتر, you might not know exactly when did it start. Okay? Because the symptoms will only develop لما يكون في advanced hyperglycemia, when the glucose is really very elevated لدرجة أنه يبتدي عند السيمتومز اللي هي البوليوريا polydipsia. Otherwise هيكون عنده abnormal glucose مسميه dysglycemia, يعني abnormal glucose بس ممكن تكون asymptomatic. Okay? Usually at presentation ما راح يكون عندنا ketones. Does this mean type 2 cannot go into DKA? No, it can go into DKA. And particular time, لما أيام الكوفيد, okay, people with type 2 diabetes, they always went into DKA. بكون type 2 جايب كوفيد و DKA, because it was such a severe infection و high stress that it tipped that body over to go into DKA. احنا قلنا to have DKA شو المفروض يكون عندي المفروض؟ ايش فيه الانسولين؟ deficiency. يعني عادة insulin deficiency مع stress بخليني أgo into DKA. فالtype 2 ما عندنا insulin deficiency. So what's going on? Because of the severe insulin resistance وعندي counter regulatory hormones اللي درستوها في الفسيولوجي زي شو? Which hormones? The glucocorticoids بالذات, the growth hormone, those things. فالسترس بتكون كتير عالية. So it's like I don't have insulin anymore. That insulin stops working. Okay, the patient can go into DKA. طيب. So the clinical presentation, as I just said, it could be completely asymptomatic. You know, you're going to be participating in events, you know, awareness, community awareness events, World Diabetes Day. World Diabetes Day will be in November. I'm sure there are going to be events, maybe you will participate. So بتحطوا booth في المجمع في الافنيوز والبيشنتس بيجوا, قصدي مش patients, the people will come ويفحص سكري أو الضغط. How many times did people detect أول مرة بالصدفة في هيك إنه طالع سكره 250 random from finger stick, and they نقول لهم please go to the health center and get yourself formally tested for this. So it could be completely asymptomatic. Okay? طيب. Or they can present with the classic symptoms of hyperglycemia اللي هي هذه. You know, the polyuria, the polydipsia, the polyphagia. and we discussed why these symptoms develop, okay, the pathophysiology of it. If anybody has any questions, please ask. Or they actually might present already be complications of the diabetes. Okay, يعني we completely miss سالفة hyperglycemic symptoms وبيجي البيشنت للعيادة يقول I have burning pain in my feet. Okay, which is a symptom of neuropathy. يعني the diabetes has been there for years وما عنده خبر خير. He doesn't know and now he has complications. Or a patient might present to the emergency room with chest pain, chest pressure radiating, diaphoresis, يكون he's having a myocardial infarction. وقت هنكتشف إنه he's diabetic. He didn't know that, okay? So it could be he presents with the microvascular or macrovascular complications of the diabetes. طيب. Much less commonly, they can present with the acute complications of diabetes mellitus اللي فيها الحالة. It could be, we said DKA, diabetic ketoacidosis زي ما قلت لكم. And it could be something else, something called hyperosmolar, يعني the osmolality is very high. Hyperglycemic, يعني if there is marked hyperglycemia. Non-ketotic, okay, يعني ketones are negative state, okay? So these complications, who does it affect usually? Usually بنلاقيها عند الelderly, الكبار بالسن, elderly people who have type 2 diabetes, who develop a problem, يعني عنده مثلا pneumonia, عنده severe UTI, صار عنده مشكلة, and this is an old patient, وطبعا السكر عالي صار because of the stress, he doesn't have free access to water, ما عم يشرب كفاية, he's losing water, وصار له severe dehydration, فالجلوكوز بيعلى, والosmolality بتعلى, ناشف, literally they are dry, and the blood is very thick, literally, okay, all right, so it's hyperosmolar وhigh, يعني الجلوكوز علوه in this state is much higher than DKA. لأنه the presentation في DKA is because of the acidosis. Yes, that's what's giving me the nausea and the abdominal pain and the vomiting. فهم بيجوا بهذا أكثر من سالفة إن الجلوكوز is so very high. أما في هالحالة it's the pure hyperglycemia. This is what caused them to become very very sick. وبيصيروا حتى they have altered mental status. ممكن يدش في كوما, يكون مبصاحي, مدروخ, دايخ البيشنت. Okay, تمام? All right. Now, what are the risk factors for somebody? Why would person A develop diabetes and person B not develop diabetes? ويكونوا بنفس العمر. Okay? شو risk factors اللي بتعرفوها؟ قلنا أهم واحدة obesity والoverweight. Okay, هاي واحدة. شنو بعد؟ مش hypertension per se, no. It's having what we call the metabolic syndrome. عرفتوا شو هو metabolic syndrome? Did you hear about it? So metabolic syndrome is that patient where you have ممكن يكون عنده كذا شغلة. ممكن يكون عنده abdominal obesity per se. يعني مش بس وزنه على الميزان, لا distribution of the fat. احنا عندنا الobesity نوعين, شكلين. في male pattern, yes, how men gain weight and how women gain weight usually. Okay? male pattern obesity is الخصر يكون كبير. So there is abdominal obesity أو central obesity بنسميها. waist circumference بيكون عالي كتير. Okay? There is the female pattern اللي هو الخصر بضل صغير but the hips get wider. Okay? Now, which is worse on the health? The male pattern. So the abdominal, لما الخصر يكبر, that's worse on the heart. That is higher risk predictor إنه يصيدهم heart disease. Okay? So metabolic syndrome إنه بيكون عندهم abdominal obesity ممكن, يعني الخصر waist circumference عالي, ممكن يكون عندهم hypertension, يكون عندهم insulin resistance أو diabetes, يكون عندهم a special kind of dyslipidemia. اللي يهمني فيها مو LDL, مو low density, لا الترايجليسرايد بتكون عالية, والHDL بتكون نازلة. اوكي؟ So high triglyceride, low HDL، هذه الديسليبيديميا تبعت الميتابوليك سيندروم اللي بتصير يعني مع هالمواضيع. اوكي؟ alright? So that's a risk factor. Insulin resistance is a risk factor to develop type 2 diabetes. Okay? Now, so what gives me insulin resistance? قلنا الweight, sedentary lifestyle، واحد بس قاعد على الكاوتش طول النهار. You know that the duration of sitting is linked to mortality. يعني كل ما ضلينا قاعدين مدة أطول، في دراسات أثبتت there is a correlation between the amount we sit and الوفيات. So this is a risk factor. So we need to get up and move. Okay? We have to move. So sedentary lifestyle is a risk factor to diabetes. من أهم الشغلات family history. Okay? So genes play a big role. بس I cannot draw a pedigree إلها. يعني it's not a monogenic, it's a polygenic pattern. تمام? We just say that family history is very important. Now, one thing I need you to تحطوه على أبدانكم, which is more important؟ يعني family history is more important للtype 1 ولا للtype 2؟ type 2. Okay, so type 1 طبعا family history، يعني مثلا إذا الأب عنده type 1 diabetes, of course his children are at higher risk to develop type 1 diabetes. But type 2 أقوى. الcorrelation أقوى. وما بعرف قلت لكم last week about the concordance studies, the twins concordance. Have you heard about this? قلت هالأسبوع الماضي. So if you have identical twins اللي هم exactly same chromosomes, exactly same, okay, so one of those twins, twin A, saw the type 1 diabetes. Yeah? The chances of twin B to develop type 1 diabetes is 50%, 60%, something like that. أما لو كان twin A got type 2 diabetes, the chance of twin B to get it is greater than 90%. Okay, so this tells me أهمية الgenetics والfamily history in type 2 diabetes. Okay? All right, so let's see what we have here. شو قلنا وشو نسينا? Okay. So also the race, the ethnic group. يعني ممكن هلا في البحرين نروح في العيادة في الملك حمد. We see a patient نقول له عندك family history؟ لا دكتورة أنا ما في family history of diabetes. أنا ما أدري من وين يعني. Just by being from this genetic pool من هالأرض الطيبة, okay, من الخليج العربي is a risk factor. Okay? Because this ethnic group ما شاء الله الجينات فيها risk for diabetes. Okay? Alright, في insulin resistant states هتتعلموها في الجايني، في شيء اسمه polycystic ovarian syndrome that ladies can develop. هذه فيها insulin resistance. So a lady مع polycystic ovarian syndrome, that's a risk factor to develop type 2 diabetes. بقول لك even prenatal exposure، يعني the baby of a mother صادها gestational diabetes. The baby لما يكبر is at risk independently انه امه صار لها diabetes. يعني just exposure to high glucose in utero is a risk factor. طيب, now what is prediabetes? So prediabetes انه انا عندي abnormal glucose, so it's not normal, it's above normal, but it's not reaching diabetic range yet. Okay, so I make my students in year 5, they have to memorize. احنا ما بنطلب منهم to memorize many things. Usually we want them to learn how to think. بس في الdiabetes I ask them to memorize it لأنه the lab will not tell you, يعني will tell you, okay, so somebody's fasting glucose is 6. هيقول لك normal range anywhere between 4 and... You need to know إنه 6 is not diagnostic of diabetes, but it's not normal. Okay? So anyway, I just, for your level, we want you to know that prediabetes is the abnormal glucose levels that are above normal but not reaching the diabetes criteria, cutoff for diagnosis. Okay? And the patient is at risk to progress to diabetes. So this is just, you know, I don't think you are required to memorize these things, but to understand it. Okay? طيب, chronic complications of any questions على اللي ما مضى؟ Yeah? Okay, so the chronic complications, it's important إنه أنا one of the target goals. Why do we treat diabetes? يعني okay, polyuria polydipsia هاي بسرعة بنحلها. The moment it drops below 250 خلاص بتروح البوليوريا polydipsia. But that's not what I aim for. إحنا the target of treatment is to prevent the big problems in the future اللي هي complications اللي هي will cost the person and cost the community a lot of resources and money and everything. Okay? All right? طيب. So the complications will happen إذا أنا عندي sustained hyperglycemia يعني الجلوكوز is high for a long time. Okay? That will put me at risk to develop complications, particularly microvascular complications. So, as we said, in type 2, it can be present at the same time. That's why, this is very important, that's why when we start screening for complications in the clinic, for the type 2 patients, we start screening from the time of diagnosis. يعني اليوم شخصته diabetic, على طول we'll start screening. We'll send them to the things that we do. ودي لدكتور العيون، ابتدي اشوف اليورين، ابتدي افحص لانه I don't know when did it start. It could have been there for some time. Okay? اما in my type 1 لا. I know when it started. تقريبا عارف الشهر اللي بدأ فيه. Okay? So no, في الادult I wait 5 years before I start screening. Or if they are children, I wait for them to be above 10 years old and then start screening. Okay? Now, الcomplications نقسمها لمicrovascular وmacrovascular. شو يعني microvascular? What is affected? The capillaries. The capillaries. The disease is في مستوى الcapillaries. Okay? Now, this it is proven, statistically proven, that I can prevent it if I keep the HbA1c less than 7%. That's why the treatment target in diabetes is less than 7% A1c. Because the studies showed me that less than 7, much less risk to get the microvascular complications. Okay? Now, macrovascular, كبرنا بطلنا capillaries, we're talking about bigger arteries. So, what arteries are my main concern لما أقول macrovascular? What arteries am I worried about? Coronary arteries, cerebrovascular arteries, peripheral arteries. Okay? So these are the 3 biggies الكبار. إني أصير لي atherosclerotic cardiovascular disease. So يصير coronary artery disease و MI وهالقصص، أو يصير strokes هتدرسوها هاي later، لا هاي next year. Okay? or peripheral vascular disease إنه يبتدي بقى تضيق شرايين، هاي أخذتوها السنة الماضية كمان، يصير له gangrene ومصايب. Okay, so these are the macrovascular complications. Now, diabetic retinopathy, this is the commonest cause of blindness in the developed world. تمام? So it is very important. يعني cost على المجتمع وعلى الناس. It's classified into في 3 things. واحدة منهم it's not a grade, it's a different type. يعني أول ما يبتدي عندي background retinopathy. I'll show you a picture. Background retinopathy, الريتنا هي قاعد نشوف لها. Okay. So this is the normal retina. Okay? The retina is the only place in the body where you actually can see the capillaries. ففعلا بقول لك العين شباك للقلب، العين شباك للقلب. You know, it's a window where doctors can look at the arteries and the capillaries and see what's going on there. Okay? So, this is a normal looking retina. تمام؟ First thing will happen في diabetic retinopathy بيبتدي عندي هاي نقط، شايف النقطة هاي؟ See those dots؟ بنسميها dots and blots. يصير مثل micro aneurysms صغيرة بتطلع، وبيطلع عندي exudates. اوكي؟ ممكن يصير hemorrhages. هاي كلها أشياء يعني في الباك جراوند، بنسميها background retinopathy. اوكي؟ Now الادفانسد إذا تم إهماله، ما ودينا على دكتور العيون، ما اهتمينا بالسكر، ما سوينا ال A1C less than 7%, it will continue to advance. What will happen؟ بيصير عندي بعدين في صورة ولا ما في صورة؟ ما في صورة. اوكي بصير عندي if you google it حطيتوا proliferative retinopathy هيصير في الكابيلاريز بتكتر، بصير new vessels طالعة، new capillaries that are not supposed to be there، لأنه الريتنا بتعاني من الإسكيميا فبتضطر تروح تسوي new vessels تطلع. اوكي هذه الفيسلز are not healthy vessels, they are fragile, they are leaky, they break easily، بصير منها bleeding ونزيف وتالي يصير في تليف وفايبروسس، وبعدين ممكن الفايبروسس هذه تشد على الريتنا وتسوي إشي اسمه انفصال شبكية retinal detachment، قصص وتسوي لي مشاكل كبيرة ولوس اوف فيجن وبلايندنس. اوكي alright. النوع الثاني اللي قلنا عنه اللي هو macular edema، it is just edema في الماكيولا. شو هي الماكيولا؟ اللي هي مركز الابصار. اوكي فانا هاي ممكن تيجي at any state، يعني ممكن تيجي مع الباك جراوند، ممكن تيجي مع البروليفريتيف، يعني this is not 1 2 3. اوكي it can happen at any time. اوكي so this is again هتخليني يصير عندي loss of vision لما مركز الابصار صار فيه edema. اوكي so ممكن يكون مثل ما قلنا ممكن asymptomatic لأما suddenly يصير لي sudden loss of vision. Okay, so everybody must be screened. How do I screen? I send them. We don't rely on our own examination. إحنا الحين الميديسن صار فيه تخصص. كل واحد واختصاصه. ما بطلنا أيام أبو قراط وميديسن وومن وميديسن مان إنه الواحد بيعرف كل شيء. No, it's not like that. Okay. دكتور العيون يفهم في العيون أكتر شيء، دكتور السكر بفهم في السكر، دكتور الكلى بفهم في الكلى. we send the patients to ophthalmologists اختصاصيين عيون to dilate the pupils and they look at the fundus وبيصوروها عندهم cameras and they look at it and they tell us how it is. Okay, so we do it at the time of diagnosis من وقت يعني من في type 2 and I do it every year. Okay, annually. And we already told you about this. Okay. In nephropathy, again, the capillaries now when موجودة في الكدني. I think next unit you will learn about the anatomy and histology of the kidney. في إشي اسمه الglomerulus where it's capillaries. That's where the kidney starts doing its work. يسوي filtration للجسم. Okay. Again, the capillaries بصير فيها مشكلة، بتصير leaky. يعني بصير the holes of the capillary مفروض ما تسمح إلا للwater and solutes الأشياء المذابة في المي إنها تنزل to get filtered في اليورين. okay. في الدايابيتك بتصير الكابيلاريز لا مثل ما تقول المشخال يعني يصير the holes of it are big فبصير البروتين يبتدي ينزل. albumin starts going down the urine. okay. alright so this is بصير في albuminuria and then it could advance and the kidney function will get affected ويصير عندي chronic kidney disease and it's the most common cause of end-stage renal disease and the patient will require either to go to dialysis or to have kidney transplant. It's because of diabetes. Okay? All right, so how do I screen it? I test the urine for microalbumin. شو يعني microalbumin؟ هو albumin. But in small amounts, we cannot pick it up بالdipstick. بتعرف عن urinalysis الdipstick? Have you heard of it before? So they dip in the urine and it tells us والله في blood, في protein, في كذا. This test في the early stages of nephropathy will be negative. There will be كأنه dipstick ما في albumin. But this is not the correct screening. The correct screening is a test called albumin creatinine ratio. هذا هي pick up the albumin in small amounts before it becomes positive. So it's important to catch them early لأنه I can do something about it to stop the progression. Okay? وطبعا اللي بيصير له kidney disease يصير it's even another risk factor for having heart disease. Okay? يعني كله بودي على كله. Okay, وصير عندهم increased risk of hypoglycemia. Anybody can tell me why? Why اللي بصير له kidney disease بصير عندهم شنو دخل الجلوكوز؟ The kidneys is a site, the second biggest site for gluconeogenesis in the body بعد liver. Okay, so if I have a failing kidney كمان I'm going to lose that function. So they become at more risk for hypoglycemia. هذا بالإضافة إنه الانسولين gets cleared by the kidney. فإذا the kidney is not working فالانسولين هيضل فترة أطول and it cause me more hypoglycemia. Okay. All right. In neuropathy, there are different kinds of neuropathies. Okay. The most common neuropathy that we see patients with هي له كذا اسم. مرات بنسميه peripheral neuropathy. مرات بنسميه sensory neuropathy. مرات بنسميه distal neuropathy. كله we mean one thing. Okay? This thing اللي هو إنه ال patients will come with symptoms in their feet and their hands. اللي هي distally. Proximal يعني قريب للمركز و distal يعني بعيد. Okay? So it is the nerve endings that get affected. Okay? طيب. What do the patients come complaining of? One of two things. Yeah, they come complaining they have a new abnormal feeling, sensation. المفروض ما يكون موجود and they're feeling it. Like what? Patients typically will come say, Doctor, I have burning pain in my feet at night. I can't sleep. I feel like there is fire in my feet. وطبعا ولا في fire ولا شيء. It's an abnormal sensation. Okay? تمام? So this is a neuropathic pain. Pain من الأعصاب. Okay? All right. Another kind of symptom مختلف. No. بالعكس. They lost their sensation. Okay? They are الإحساس نعمة. They lost the feeling in their feet. فهو ممكن يكون لابس نعال وماشي في الشارع رايح بيتهم يوصل البيت فردة موجودة وفردة راحت في السكة ما حس فيها. ما حس إنه ممكن دخل في رجله مسمار دخل في رجله زجاج وهو أبداً ما في pain. ال pain is gone. Okay? فببتدي مشاكل والتهابات و ends up بشنو؟ بamputation. Okay? All right? So negative symptoms I lost the feeling أو positive symptoms عندي pain عندي كهرباء عندي أشياء أحس بدبابيس في رجلي. Okay? All right. So how do we examine it? How do we screen for it? We examine the feet. We have to examine the feet in a neuro kind of examination. طيب. Another kind of neuropathy تبع autonomic nervous system. لسه يمكن ما درستوا سمعتوا عن autonomic nervous system? Okay. All right. So autonomic nervous system اللي هي visceral systems, visceral functions. So I don't have, it's not painful. Okay. Pain is a somatic thing. بس الvisceral يعني مثلا إذا affected the genitourinary system ممكن المن they come with erectile dysfunction and this is a big one. This is a very popular and very important side effect. Okay, بتغير حياة الناس. Another thing is ممكن في GI the stomach becomes كأنه weak أو paralyzed. It's not emptying. نسميها gastric paresis. So people will eat the food and بعد 3 4 5 ساعات للحين الأكل مثل ما هو ما انهضم. Because it's not emptying. It's a neuropathy. Okay? Okay, this is just to show you how we examine the feet. This is called a monofilament test. It's testing the pressure, هذا vibration, to test the vibration sense. كل هذا رح تدرسوا later in your medical school. طيب. Back to diabetic neuropathy, there is something else called a mononeuropathy. شو يعني mono؟ هداك قلنا عنه polyneuropathy اللي هو يعني small nerve finding endings كتير منهم get affected distally. أما هذا I have one nerve, just one nerve loses its function. Examples, it could be one of the cranial nerves اللي في الرأس. مثلا the ones controlling the eye movement. اللي هم رح تدرسوهم كلهم هاي 3, 4 and 6 are cranial nerves that move our eyes يمين ويسار وفوق وتحت. So if one nerve gets affected, the patient suddenly will come say, Doctor, I can see 2, double vision. نفحصه يكون عنده new squint, new developed squint, okay? Or they can come with Bell's palsy, إنه نص وجهه ما بيتحرك, 7th nerve. أو جايب foot drop. المهم إنه it's one nerve that gets affected, but thankfully this is self-limited. يعني usually function comes back. Okay. طيب هاي مش مهمة. This is just an example of how a new squint can develop. Third cranial nerve palsy. طيب Macrovascular complications قلنا يعني the bigger arteries. فالcoronary, cerebrovascular, peripheral. Okay. Now, it is very important to know the underlying mechanism تبع هالموضوع هو الأثيروسكليروسيس. وهذا درستوه in detail last year, right? ونعرف إنه الأثيروسكليروسيس is not one thing. It's many things coming into play. Okay? يدش فيه blood pressure, ويدش فيه lipids والكوليسترول, ويدش فيه inflammation, ويدش فيه genetics, smoking. So many risk factors are there for atherosclerosis. وطبعا diabetes is one very important risk factor. Okay? But the idea here إنه I need to know إنه it's not as easy as if you keep your A1C less than 7%, you're not going to have an MI. Unfortunately, it's not like that. So, controlling the glucose is very important for microvascular complication prevention. And macrovascular, it's much more than that. Right? The number one cause of death for people with diabetes is cardiovascular. MI, stroke, okay? Something will happen there. Tamam? So, to prevent them, then I need to do more. I need to control all the risk factors. Yes, I try to get the sugar under control, the blood pressure under control, that LDL I need to make it down to target, okay, and the target for diabetics is very low, not like the normal people, okay, very low, okay, and if he's smoking, you have to stop smoking. If they're overweight, you need to lose weight. If they have a sedentary lifestyle, start walking. Okay, so they cannot change their family, his something, or his sex, his gender. We cannot do that. They do it in other places in the world, but we don't do that here. So, okay, so this is what I'm talking about. Multifactorial risk reduction for the diabetes. Okay, and طبعا, if applicable, when applicable, we also use aspirin. It's very important now to know that صار عندي هلأ في المانجمنت في الفارماكولوجي اللي درستوه there are certain drugs that have very high value to protect the heart from this problem in a diabetic patient. Okay, so now in our clinics, anybody who a diabetic who has already had an MI, and he comes to us, he's diabetic وصار MI أو unstable angina أو صار stroke okay. What do we as diabetes doctors have to do? It's not just bringing down the A1C to less than 7. It is what are we using? What medicine are we using? So he must be on a GLP-1 analog or receptor agonist or GLP-GIP, هذا the newest, the Monjaro. Okay, so they must be on those, one of them. Okay, or على SGLT2 inhibitors. لأنه those were proven. People who are taking those medicines, mortality will become down, and the risk of having other cardiovascular events will be less. Okay? And also now the SGLT2 is very useful for diabetic nephropathy. يعني غير الheart, it's useful for the kidneys. So if they already have albumin in the urine, they better be on that SGLT2 inhibitor. It will protect their kidneys from progressing. Okay? I think that's all I have. Do you have any questions to me, or do we have Dr. Yahya here, physiology? The most fundamental thing to understand is the physiology in these things. Yes, تفضلي.
Doctor, I have a question. Doctor, regarding the type 2 diabetes, there is a balance between the beta cell secretion and alpha cell secretion, or it's lost? Since there is a paracrine signal between the beta cells and alpha cells.
شوفي, yes, of course, in the pathophysiology, and I think Dr. Yahya maybe focused more on pathophysiology of type 2. I have many things going on. It's not just one thing. So yes, there is beta cell dysfunction starts. So it's not just pure insulin resistance. There's also beta cell dysfunction, okay, and impairment in that. The beta cells affected, the alpha cells will get affected, the incretin secretion is affected, the kidneys will gluconeogenesis في liver, multiple things that all will lead to بعدين يصير عندي الهايبرغلايسيميا والديفلوبمنت اوف diabetes
So
type.
we can see like elevated levels of glucagon in the blood.
I'm sorry?
We can see elevated levels of glucagon in the blood. Or
In type 2, do you see elevated levels of glucagon in the blood? We never measure glucagon in the blood.
انا جاي مخصوص عشان السؤال يعني.
اه والله طيب. Here.
لا لا خليه دكتورة يا جماعة. أنا asked a very يعني provocative question in which